Good afternoon, Vikas.
Good afternoon, sir. So I was just asking about you from
Thank
Piyush.
you, thank you,
Yeah.
thank you
So
for
you're
joining.
you're in Nepal.
Good afternoon, Dr. Shahidur. Dr. Shahidur Rahman is one of the senior surgeons from Bangladesh. He's been
Okay.
regularly attending our sessions.
Mhm.
So I welcome all the participants in this another session of Jaipur Surgical School. Just to have a brief introduction about this online initiative. So we are running for almost last 5 months now. It was started in October first week under the able guidance of Professor V.K. Kapoor. The topics are particularly designed to enable and help general surgical trainees, especially final year trainees in the low and middle income countries like Nepal, Bangladesh, and other countries from Middle East. And we are continuously trying to improve this program from the inputs of our members. I further request Kapoor sir to add on and introduce this today's speaker for the topic of obstructive jaundice.
So today is a very important topic because any surgical exam, postgraduate exam, even undergraduate exam, one of the long cases is very, very likely to be a patient with jaundice. So how to evaluate a patient with jaundice and how to plan the management, including investigations and treatment, is something which every surgical student is expected to know. And I can assure you that if you do well in your long case on jaundice, it is very likely that examiner gets a very good impression of you. And even if you don't do so well in the other cases, you may pass. But if you don't do a patient with the obstructive jaundice well, then you will have to perform very, very well in other cases to cover that up, because this right iliac fossa lump. These are common cases: a palpable gallbladder, a bleeding rectum. So every student should know, and I think there could be no better speaker on this than Dr. Vikas Gupta, who has had a long stint as a faculty member at the Postgraduate Institute of Medical Education and Research, which is one of the premier medical institutions in the country for a long time. And recently, he has moved to the NMC in Abu Dhabi as a consultant GI surgeon. So with that, I request Dr. Vikas to please start his presentation. And as I have pointed out in earlier sessions, the this Zoom link is only for faculty, so there are only 10 people, but all our previous sessions have had good number of views by surgical students and general surgeons, and therefore whatever effort our faculty is putting in is coming to use by a large number of students and even practicing surgeons. So Vikas, please.
Yeah. Thank you, sir. Thank you for the nice words. So
Please.
the topic given to me is approach to surgical obstructive jaundice, or what we interchangeably use as surgical jaundice, or this thing obstructive jaundice. So just before I start my talk, a brief overview of the bilirubin metabolism. That's innocent red blood cells are being broken down, and bilirubin is made from hemoglobin, and the main process of bilirubin is conjugation occurs in the liver, and which is then excreted through the bile ducts into the intestine. And some of the bilirubin is this bile salts and bile pigments are reabsorbed as enterohepatic circulation, and some of the then in the intestine the this thing bile pigments, bile salts, they are converted into urobilinogen and stercobilinogen, which is excreted through urine and feces respectively. So this is in brief the metabolism. And if we patient of jaundice walks in to your clinic, so it's not like that if you are sitting in a surgical clinic, it's always a obstructive jaundice. So you have to see whether it is a prehepatic, hepatic, or post-hepatic jaundice. Because prehepatic is when there is increased breakdown, hepatic is when there is abnormal conjugation, and post-hepatic is when everything is okay but there is abnormal excretion. So this is how we differentiate into three. So there are various biochemical and lab parameters which can differentiate this jaundice. Hepatocellular jaundice will have, both the jaundice will have increased bilirubin. However, alkaline phosphatase and gamma GT will be more higher in obstructive jaundice compared to hepatocellular, and deranged coagulation will be more pronounced in obstructive and hepatocellular both, but enzyme elevation will be more marked in hepatocellular jaundice compared to obstructive jaundice. And important thing is that urine urobilinogen and feces stercobilinogen will be absent in obstructive jaundice, cholestatic jaundice, decreased or absent in cholestatic jaundice, and in hepatocellular jaundice, it will be present or it can be raised also. So how does jaundice affect the physiology of the body? It affects bile acids are very important. It affects the immune system of the gut. It affects the coagulation disorder. It affects the this thing in gut permeability, and it affects the kidneys and heart as well. So jaundice has been long associated with anorexia and malnutrition. So what causes anorexia? It has been seen that when there is no bile going into the duodenum, there is no negative biofeedback. So the cholecystokinin levels will keep on increasing. So this is a graph to show that as the cholecystokinin level is increasing, the patient will become more anorexic and the patient caloric intake will gradually decrease down. And on the contrary, if these patients are drained, the appetite and anorexia improves, and this improvement is more marked in patients with benign jaundice compared to patients with malignancy, underlying malignancy. Second important element is the coagulopathy associated with the jaundice, because bilirubin bile is not reaching the intestine, so bile has got an important function in absorption of fats.
É,
So sorry.
Marcelo,
Yeah. So there will be patients will have steatorrhea, and because of the fat malabsorption, the fat soluble vitamins A, D, E, K will not be absorbed. So vitamin A deficiency can manifest as night blindness, and vitamin K dependent many coagulation number of coagulation and anticoagulation factors are being synthesized in the liver. The synthesis will go down, and the patients can have deranged INR, and they can have coagulopathy. And on top of that, patients who have recurrent obstruction, patient who have low grade cholangitis, patient who have prolonged obstruction is not drained for a long period of time, they can have some amount of hepatocellular damage, which can also contribute to the coagulopathy. And patients with these hepatocellular damage and liver fibrosis can have splenomegaly, and as a result of which they can manifest as thrombocytopenia. Intestinal permeability and gut barrier is an important function, and in the absence of bile acids in the intestine, the gut permeability can increase. T cells have been shown to increase with the stimulus from the bile acids, and it has been seen that the absence of bile acids in the intestine leads to reduced CD4 and CD8, which are again protective cells for against many infections. Bile acids act as biological barriers by inhibiting the growth of these variety of organisms, because bile being an organic solvent tends to lyse the bacterial cell wall. So when the bile is not reaching intestine, automatically the bacterial overgrowth occurs, and this overgrowth is mainly gram-negative bacilli. And bile binds the endotoxin and bacteria, and it prevents the translocation of bacteria across the gut barrier. So in the absence of bile acids, the bacterial translocation do occur. So this is just a schematic representation which shows that in the absence of bile acids, the intestine get atrophied, because bile has got a positive stimulation for the proliferation of mucosa and mucosal growth and repair, and it helps in maintaining these tight junctions. So in the absence of bile, the mucosal atrophy occurs, the junctions become leaky, and all these promote to the development of portal endotoxemia. Endotoxins get absorbed across the intestine, and then the more endotoxins are involved, it releases more of the systemic inflammatory response, and it affects the entire body. Yeah. Then another third important dysfunction which occurs in obstructive jaundice is renal dysfunction. This is a very old article which I have deliberately quoted here, wherein 130 patients of cholangiocarcinoma were evaluated, and 49% of them had acute renal failure. But over a period of time, the incidence of renal failure has decreased, come down with better understanding of the pathophysiology. However, the mortality associated with acute renal failure in the presence of obstructive jaundice is as high as 70 to 80%. With fluid therapy, the procedure-related incidence has come down to 10%. And with fluid therapy and better management, the incidence has come down. So how does bile acids cause renal injury? Because when the bile duct is obstructed, all the bile acids are being absorbed in the systemic circulation. Under normal physiology, 100 micromole of non-protein bile acid is received by GFR. When the obstructive jaundice is there, it overloads the renal tubules beyond the reabsorption capacity, and this directly damages the kidney. So this is what is called as cholemic neuropathy, cholemic nephropathy, or obstructive jaundice kidney injury. And second mechanism is the indirect injury of the kidney because of the underlying cardiac dysfunction, endotoxemia, altered hemodynamics because of the jaundice, liver hemodynamics, permeability is increased. Renin-angiotensin system activity, pro-inflammatory mediators are released. So all these contribute to the indirectly to the occurrence of renal injury. Even low serum albumin, which promotes the fluid to be accumulated in the third space, again decreases the oncotic pressure, and again it promotes in the development of the kidney injury. So this is again a photograph which shows the direct mechanisms of cholemic nephropathy, wherein the increased bile acid concentration is in there in the renal tubules. The pro-inflammatory mediators are being acting on this. Oxidative stress, low perfusion states, all these will cause cast nephropathy in these patients. Similarly, cardiovascular effects are responses are blunted in patients with bile with excess of bile acids in the blood, and they impair the conduction and contraction of the heart. Depletion of glycogen in the cardiac myocytes, they promote arrhythmias in the form of prolonged PR and QT intervals. So this is the how it affects that bile salts. They lead to endotoxemia, decreased clearance of cardiotoxin. All these factors, they contribute to renal and cardiac dysfunction in these patients. So once we have understanding of the effect of obstructive jaundice on the body, and we have differentiated the patient of jaundice that it is a obstructive jaundice, these are the few questions which we need to ask yourself. We need to answer whether first and the foremost thing is the patient in cholangitis. Number one. Second is what is the level of obstruction and what is the cause of obstruction. Thirdly is drainage required for this patient. And fourthly, what is the definitive management in these patients. So cholangitis is the most important component in patients with obstructive jaundice because it is an infectious condition of biliary system. And as we know that running water is always clear and stagnant water is always contaminated. Similar situation is there in the biliary system. Whenever there is obstruction, bacterial colonization, if occurs, it can lead to infection, and this infection can be life-threatening. And if we see the data that even in 1970s, early 70s, the mortality associated with severe cholangitis was 50%, which has reduced over a period of time. But in severe cholangitis, mortality is as high as 10%. And if it is untreated, it leads to SIRS and can be fatal. So biliary obstruction, if we understand the pathophysiology, that the normal secretion of bile secretion occurs at a pressure of 12 to 15 millimeters of mercury. The pressure in the bile duct is 10 to 15 millimeter of mercury, and this is being regulated by the sphincter of Oddi. And if there is superimposition of bacterial infection ascending, either it can be ascending from the duodenum or from the portal pyemia, can lead to cholangitis if this system is obstructed. So what happens when the pressure goes as high as 20 millimeters of mercury in the bile ducts? There is widening of the space of Deci, and through which the cholangiovenous reflux can occur. And at a pressure of 25 millimeters of mercury, the cholangiovenous reflux starts. That means the bile bacteremia and the bile salts, they start pouring. Instead of going antigrade into the bile ducts, they start going into the circulation through these widened spaces of Deci. And beyond the pressure of 30, there is total cessation of excretion of bile. Diagnosis of cholangitis was described way back in 1877 by a triad of colic, fever, and jaundice. And however, this triad has a specificity of 95% even today, and a sensitivity, low sensitivity. But again, with presence of mental confusion and shock, in 1959, Renal and Dragon, they described it as a Reynolds pentate, and this is a fatal condition. And we can diagnose cholangitis by classical symptoms of pain, fever, and jaundice. And this triad is present in 60% of the patients. And whenever we are evaluating a patient of jaundice, this is again a question whether the patient is cholangitis. And again, in patients with extremes of age, there can be very subtle signs of cholangitis. Patients with immunocompromised, patients with liver transplant who develop anastomotic stricture, they can have very subtle signs of cholangitis. So in these group of patients, one has to be very careful. And again, it manifests as leukocytosis, elevated CRP, deranged liver function test, and tumor markers done in the presence of cholangitis are unreliable and they can be elevated. So it should not be done whenever we see a patient of cholangitis. And procalcitonin has been long used as recently being used as a marker for infection, and unlikely CRP, which is a non-specific inflammatory marker. And this is a study where they have seen that if procalcitonin is used instead of CRP, the incidence of severity grade of cholangitis increased by 15%. So, as a protocol, many centers before contemplating any major liver or hepatobiliary surgery, we will always use procalcitonin as a preoperative screening to rule out any infective focus in the body. So in 2018, the Tokyo guidelines were revised, and basically based on these criteria, cholangitis is diagnosed. Systemic symptoms of inflammation in the form of fever and chills with lab data on elevated CRP. B is cholestasis, presence of jaundice and lab data with abnormal liver function test. C is biliary dilatation and or identification of any etiology on imaging in the form of stricture, stent or stone. One is to suspect cholangitis if A, that means inflammation is present in the presence of deranged liver functions or biliary dilatation. Definitive diagnosis is when all the three are present. That means that is there is deranged liver functions, there is evidence of systemic inflammation, and there is presence of biliary dilatation or some etiology associated with cholangitis. And these are the threshold values. That means threshold values for diagnosing lab data regarding systemic inflammation or cholestasis. Systemic inflammation will be detected by elevated WBC and CRP, and liver function abnormalities, all SGOT, PT, and alkaline phosphatase and gamma GT are considered. So based on this data, cholangitis is divided into three severity grades. Grade 1, which doesn't fit into any two. Basic concept is that grade 2 cholangitis is with abnormal findings on biochemical data is abnormal, and grade 3 cholangitis is cholangitis which is associated with the presence of organ failure. It can be either cardiovascular failure, neurological failure, respiratory dysfunction, or renal dysfunction. Any organ failure makes it a grade C cholangitis. And because on why it is important to segregate cholangitis, because the treatment or management is based on the severity grading. Antibiotics are sufficient for mild grade cholangitis and the patient is responding, then subsequently we can plan the treatment of definitive etiology. Grade 2 cholangitis, antibiotics and supportive care if and early drainage is recommended. And grade 1 has to be monitored regularly. If the patient progresses to grade 2, then biliary drainage will be required. And grade 3 cholangitis, again, they require urgent biliary drainage within 24 hours. And this is when you should consider transferring the patient to a higher center where the facility of endoscopic or some kind of drainage is available. Grade 3 cholangitis, all patients should be transferred to a center where this facility is available. Mild grade cholangitis should be observed for 24 hours. If they don't improve within 24 hours, then they can be considered for transfer to a higher center. After we have ruled out cholangitis, we have managed cholangitis. It is the responsibility of clinician to have a clinical evaluation of the patients with obstructive jaundice. Pain is a very important symptom because there are a list of causes which causes painless jaundice and which cause painful jaundice. Painless jaundice is mostly due to malignancies, early malignancies like hilar cholangiocarcinoma, periampullary carcinoma, or mid CBD cholangiocarcinoma. They will cause a painless jaundice. However, painful jaundice is more harbinger of a stone disease like bile duct stones or carcinoma gallbladder. They will have pain many of them, and carcinoma pancreas will have a typical pancreatic pain. And again, the progress of the jaundice is very important because if it is gradually progressive and it is gradually increasing, that means it shows completeness of obstruction. If the obstruction is complete, that in itself is an indicator that it is likely to be a malignant cause of the jaundice. However, partial obstruction, like in stone disease, there can be waxing waning. Only malignancy where we can see waxing waning is the periampullary carcinoma, and where due to the tumor sloughing from the ampulla can transiently decrease the jaundice, and again it can manifest as increasing jaundice. And whenever there is partial obstruction, the there is high likelihood of patients getting fever and cholangitis because the duodenal ampulla or whatever the site is obstruction is not totally cut off from the GI tract, and some of the bacteria, some of the inflammatory change, this thing in bacterial colonization can occur in the biliary system. Pruritus, again, the severity of pruritus has to be evaluated in these patients because this is a symptom which can be very distressing, and this can be an indication of early drainage in these patients. And of course, the presence of constitutional symptoms have to be evaluated. And again, performance status of all these patients should be evaluated because we need to plan a definitive management in these patients. Clinical examination, we should always look for in these patients the evidence of liver dysfunction, because prolonged cholestasis or presence of recurrent cholangitis can lead to liver dysfunction in these patients. So for particularly for patient students who are appearing for the exam, you should always look for these signs from in the form of liver dysfunction, fetor hepaticus, Kessler-Fleischer rings, and then scratch marks, gynecomastia, testicular atrophy. All these signs should be mentioned as a part of your clinical examination. Second examination, in second important thing which we need to rule out in these patients is presence of hepatomegaly, which will invariably be there if the patient is not drained. And presence of splenomegaly is important, which in itself indicates can be because of portal hypertension, secondary to portal hypertension, or can be because of underlying liver dysfunction. Thirdly, is the gallbladder palpable? This is a important sign which can clinically give you a clue regarding the level of obstruction. And again, signs of portal hypertension should always be looked for in these patients, because portal hypertension in this patients can occur because of the fibrosis associated with the jaundice secondary to liver dysfunction, or many patients with portal biliopathy can present with jaundice as a first finding, and then there can be a telltale evidence of portal hypertension, or in malignancy there can be tumor involvement of the main veins, and which may or may not lead to some clinical evidence of portal hypertension. So level and cause of obstruction, again, after clinical assessment, if the gallbladder is palpable, which will be palpable only in 30% of the patients with periampullary carcinoma, we can have a fair idea of level of obstruction. So if the obstruction is below the level of insertion of cystic duct into the bile duct, the gallbladder will be palpable. But only 30% will have palpable, and we all know that Courvoisier law that whenever in a patient with jaundice gallbladder is palpable, it is seldom due to stone disease. So it indicates that the obstruction is below the level and it is not due to stone disease. And if the gallbladder is not palpable and patient is clinically looking like a malignant obstruction, the obstruction is likely to be at the level above the level of cystic duct insertion. Sometimes tumor in the Hartmann's pouch in the GB neck can lead on to palpable gallbladder. And other exceptions to Courvoisier law is mucocele of the gallbladder, double impaction of stone, or empyema of the gallbladder, which all can lead to a palpable gallbladder with jaundice. If we see the etiology of jaundice, most 70% of the patients will have a benign etiology in the form of polydocholithiasis and cholelithiasis, benign biliary stricture, recurrent pyogenic cholangitis, parasitic diseases, choledochal cyst, autoimmune diseases of the liver, autoimmune disease like autoimmune IgG4 related pancreatitis, IgG4 related hilar stricture, and then portal biliopathy can be important cause in patients with in an Indian scenario where we see a lot of portal hypertension. And malignant etiologies, they only contribute to 30% of the patients with malignancy. This can be periampullary carcinoma, head carcinoma, carcinoma gallbladder, extraneous compression, or hilar cholangiocarcinoma. And this is just a picture to show this is how the tumor. So we can always classify it as the causes within the wall, like the stone disease, inside the lumen like a stone disease, within the wall like a tumor, and outside the wall like compression by some lymph node or compression by some tumor. This can lead on to jaundice. So in 1983, Benjamin gave this classification, I think, which is still relevant as of today. So type 1 is the complete obstruction, where there is total obstruction. He just mentioned about the lower CBD. He didn't mention much about the intrahepatic hilar cholangiocarcinoma. That type 1 obstruction is complete obstruction, where there is total obstruction of the lower end of the bile duct. And this can happen in CA head of pancreas. Type 2 is intermittent obstruction, as happens in choledocholithiasis, choledochal cyst, or periampullary carcinoma. Type 3 is incomplete obstruction, but it is chronic, as happens in bile duct stricture. It can happen in chronic pancreatitis, biliary stricture associated with chronic pancreatitis, or strictured hepatococcinectomy. And type 4 is segmental obstruction, as we see in recurrent pyogenic cholangitis or intrahepatic cholangiocarcinomas or sclerosing cholangitis. So when we have evaluated the patient clinically, it is important to differentiate biochemically and clinically whether we are dealing with a benign jaundice or we are dealing with a malignant jaundice. If we see clinical parameters, benign will have waxing and waning, while malignant will have gradually progressive jaundice. Palpable GB can be seen sometimes in benign, in malignant obstruction. Cholangitis is more common in benign disease. Bilirubin levels are usually not more than 10 because the obstruction is always intermittent and incomplete. However, the bilirubin will be more than 10 because obstruction is going to be more complete. Pruritus will be more in malignant jaundice compared to benign jaundice. Alkaline phosphatase and GGT will be comparatively more higher on the higher side in malignant jaundice. Urinary urobilinogen and stercobilinogen will be totally absent in malignant jaundice with complete obstruction, and obstruction will be complete in malignancy compared to benign disease. So once we have evaluated clinically, so we need to investigate these patients about the level and cause of obstruction. So ultrasound is a very good screening modality. However, the problem with ultrasound is very much operator dependent, and it can detect the whether the bile duct is obstructed or not in with about 90% accuracy. However, the level and cause of obstruction is difficult to establish on ultrasound because sometimes lower part of the bile duct, particularly retroduodenal and intrapancreatic bile duct, can be difficult to visualize on ultrasound. Many people have advocated putting a Ryle's tube and aspirating the duodenal air to better visualize this, but again, that will be more invasive and that will be more inconvenient for the patients. And CBD stones can be seen on ultrasound in 20 has a sensitivity of 25 to 50% on ultrasound, but if they are seen, the specificity will be high. And over in the last decade or so, contrast ultrasound has evolved. And again, we give a contrast intravenously and see the enhancement pattern of the tumor if we can see and we can identify the etiology of the obstruction. However, again, this is a very operator dependent modality, and it has all the limitations of ultrasound, whether we give contrast or we don't give contrast. CT scan is an important imaging modality which can tell us about the etiology of the lesion. Level of obstruction can be assessed as accurately as 90% of the patient, 90% of the cases, and it can differentiate very easily between benign and malignant conditions in about 93% of the cases, and it gives us a good roadmap for planning further management. We can assess all the vascular structures as we can see here. This is a hilar block with atrophied with attenuation of the left portal vein. That means this is involving the left portal vein. So what we need to at this upfront doing a CT, we can plan that this patient will likely to need a left hepatectomy. And this is again a CA carcinoma head of pancreas with a clear plane between the superior mesenteric artery and the vein. So this means we can go for upfront resection if suitable in this patient. And however, the problem with CT is it's not a very good modality to pick up stone disease in the bile duct. And CT should not be, CT is usually not a part of workup for the stone disease for evaluation of the stone disease. So over the last decade, CT cholangiography has been evaluated and it has come up. So basically what we are doing here is we are infusing the cholangiographic contrast in the intravenously, and it is dependent upon the hepatocyte function. The contrast is being excreted into the bile duct, and it is better visualized by taking serial images on CT scan. And with this modality, the detection of stone has got a high sensitivity and specificity, which is as equivalent to MRI as equivalent to as good as MRI. And people say that this can be a one-stop solution for evaluation of obstructive jaundice. However, the problem with this modality is there is a lot of radiation exposure which is happening to these patients, and the dose of contrast which is required to visualize this bile ducts is very high. So many patients are allergic and contrast-induced problem, nephropathy, these are there. So this is uh, described, but this is not being put into much of practice over a period of time. This is only limited for people who cannot undergo MRI, who are claustrophobic, or in whom we cannot, the patient cannot stay still for 15 minutes or so to get the MRI done. So this modality is being evaluated there. MRI and MRCP is a very good modality. This relies on the heavily weighted T2 weighted sequences on MR acquisition, and the modality can delineate the bile ducts above and below the level of obstruction, as you can see here, and it can it can detect the etiology of the underlying condition. It is very good modality for evaluation of polydocholithiasis, iatrogenic strictures. As we can see here, this is a right and left duct, and there has been iatrogenic stricture with complete cutoff with a cutoff at the level of confluence. And this is again a stone disease in the stone in the gallbladder neck, which is causing compression of the bile duct, causing a Merisi syndrome. And for hilar cholangiocarcinoma, this is again a good modality. And with the use of contrast MRI, this can also be a one-stop solution to evaluate the vessels, as we can see on CT scan. With MRI, the sensitivity and specificity for level of obstruction is as good as 95 to 97%. And for polydocholithiasis, again, it has got a good sensitivity and specificity. However, the problem with MRI is that if the stone or filling defect is less than 6 mm in the bile duct, then the sensitivity decreases. It cannot differentiate whether it is a stone disease, sludge, or a tumor. So ERCP came into the ERCP is used for past so many years, but as of today, there is no role of doing a diagnostic ERCP. It is only done if we are planning some therapeutic intervention, because we plan to do sphincterotomy or we plan to do invasive imaging, biopsy, sphincterotomy and stenting is to be done. Biopsy is taken, brushings and cytology are to be taken. So in those cases, we need to plan ERCP. It's an invasive tool, but again, we have to bear in mind that each ERCP it comes with a bit of complication, 5 to 10% incidence of complication, and 0.02 to 0.5% risk of mortality is there. And post ERCP pancreatitis is the most common complication. And of course, technical failures associated with ERCP have also been significant, has also been there. So this procedure should not be taken lightly. Endoscopic ultrasound over the last 2 decades, there is a lot of enthusiasm and people have been doing it very rampantly, and it has got a very good diagnostic accuracy. And for polydocholithiasis, people combine endoscopic ultrasound with ERCP. And if the stone is there and at the same sitting, ERCP can be done. And for CBD stone, it has got a fairly good sensitivity and specificity. It has got a therapeutic potential also. And for third space and a third space endoscopy is also a possibility, has been made realistic by the use of endoscopic ultrasound. Sometimes patients with large tumor in the head of pancreas, they cannot undergo drainage because you cannot see the papilla, you cannot see the papilla, you cannot inject, you cannot locate the bile duct. So people transduodenal puncture of the bile duct, transduodenal choledochondrostomy has been described, and sometimes patients with hilar block, like patients with CA gallbladder, transgastric drainage into the left duct has also been described with the use of endoscopic ultrasound. And of course, whenever we see like this, we can see the bile duct on the endosonograph, and there is a stone inside the bile duct. And in this patient, we can see a large tumor close to the portal vein. And we can always take a biopsy, and FNAC true cut, duodenal true cut biopsy can be taken using endoscopic ultrasound, and FNAC can also be taken from a suspicious lymph node to better delineate the and to have a better to achieve a diagnosis. Invasive imaging, again, last few years, again, this has also been come. Cholangioscopy, direct cholangioscopy is a possibility. It can be done either by using endoscope, putting a mother baby scope going into the duodenum and then cannulating the bile duct. And from the working port of the endoscope, we can put another scope to visualize the bile ducts. Or we can do percutaneous using a PTBD catheter track. Through we dilate the track and put a cholangioscope, and intraoperatively cholangioscopy is done, particularly when we are doing laparoscopic bile duct, common bile duct exploration. Role of intraoperative cholangiogram has also been described, but over a period of time, over the last few years, this role has decreased significantly. And intraoperative ultrasound to delineate the bile duct is also, again, the role has becoming less and less. So site of obstruction, again, we can see this, the role of CT scan, as I was discussing, a tumor here, we can plan resection. CT scan can give us a roadmap for the vascular lesions. So we can see a large tumor here. So this patient can be referred for palliation and endoscopic stenting, so that we can plan neoadjuvant therapy in this. Again, patients with hilar block, we can see a tumor here which is blocking the hilum. So that means this patient is likely to have right liver resection. So we need to drain the left system. So we can upfront plan this procedure and then define the subsequent management accordingly. Again, biliary lithiasis as seen on MRCP, and this can be seen on endoscopy also. And if like this situation is totally packed with bile ducts, so this is not suitable for endoscopic clearance. Again, if a small lesion, small stones like this is seen, with this can be cleared on endoscopy. Biliary stricture, post-cholecystectomy biliary stricture, we see quite often, and again we can see type 3 and a type 4 stricture, and MRCP can very well differentiate, very well delineate. And again, we need to see that the bile ducts are not very much crowded, so that means there is no atrophy of any either segment of the liver. So again, biliary, sometimes we encounter biliary parasites. We can see ascaris into the bile duct. We can see the hydrated membranes in this bile duct. So these things can be encountered. And again, multiple level obstruction, as we can see here, multiple intrahepatic stones with in the left lobe of the liver with sparing of the right lobe of liver. And the left lobe has undergone atrophy, and there is compensatory hypertrophy of the right lobe. And likewise, PSC, again, we can see multiple strictures. And so these patients, they require multiple stents or definitive management as per the need of the patient. Again, lower CVD obstruction, we can see the two scenarios. Again, we see a complete cutoff, the straight line. This is complete cutoff of the bile duct. So this is a hallmark sign for malignancy. And we can see here a smooth tapering of the bile duct into the duodenum, and dilated pancreatic duct can also be visualized here. So this looks like more like a chronic pancreatitis. Malignant hilar blocks can also be delineated, and management can be planned accordingly. So once we have defined the level and site of obstruction, level and cause of obstruction, so the next question which needs to be answered is biliary drainage. So do the patient require drainage? So what are the group of patients which require drainage? Patient related factors which determine drainage is the presence of cholangitis, as I have discussed earlier, presence of malnutrition where the patient cannot be subjected for direct surgery. Optimization of comorbidities, patient has got cardiac or pulmonary comorbidities which take some time. Intractable pruritus, which is disturbing his sleep, which is disturbing his day-to-day activity, is another indication. And when there is anticipated delay in the definitive surgery, so these patients should be subjected for biliary drainage. So biliary drainage, disease-related factors. So patient needs a therapeutic procedure, like a patient with gallstone and bile duct stone. So the bile duct needs to be cleared prior to surgery. We can subject these patients to biliary drainage. Patients who are planned for neoadjuvant chemotherapy and radiotherapy, many obstructive jaundice patients like locally advanced pancreatic cancer, they need neoadjuvant therapy. So they need biliary drainage prior to any intervention. Liver optimization required. Patients with hilar cholangiocarcinoma who have small future liver remnant, volume of the liver remaining after surgery will be less, so they need some kind of portal vein embolization. Biliary drainage is required in these patients. So most of the people will agree that patients with hilar block with high jaundice, they should be drained prior to any surgical resection. And again, patients who need vascular resection, there is again a debate whether they should be drained to, but to my mind, they should be drained because a cholestatic liver tolerates the clamping of the portal vein and the hepatic artery very poorly compared to normal liver. So hilar blocks, they will require drainage, some kind of drainage. But again, there is a lot of controversy regarding the lower bile duct blocks in the absence of cholangitis and at what level of bilirubin the drainage is to be done. Usually, there is no guidelines on this, but usually most of the people will agree that if the bilirubin is beyond 20 milligram per deciliter, they should be drained. And for the lower level block, the drainage, again, there are many trials, and there is I will just come to that, if whether to drain the lower bile duct blocks in the absence of cholangitis. So before we attempt any endoscopic or surgical intervention, there are few strategies which should be taken care in these patients so as to prevent the ill effects of the obstructive jaundice. So we should try to minimize trauma when the patient is deeply jaundiced. We should give good antibiotic prophylaxis, adequate fluid replacement, enteral nutrition, and immune nutrition to prevent mucosal atrophy, and sometimes lactulose, again, that is debatable. Use of lactulose is debatable. Preventing renal injury in these patients require good amount of hydration, biliary drainage, and there are many trials which have shown dopamine and mannitol, but they have not been proven of any benefit. Recently, N-acetylcysteine has been found to be of some use in the patients in preventing renal injuries. But again, we are still lacking on level 1 evidence. All these patients, before any intervention, they needs correction of coagulopathy, use of antibiotics, and for elective coagulopathy is corrected with use of vitamin K in the injectable route, because and fresh frozen plasma if the coagulopathy still persists after vitamin K. Antibiotics based on the local antibiogram, and all cholangitis patient need to be treated. Elective procedure, we need to give only prophylactic antibiotic, and we always send the bile for culture. And if a patient who has been previously stented, whether to give, we can give antibiotic for a longer period of time. So this is the bacteriology of the cholangitis. Most of them, these are enteric bacteria which are colonizing into the bile duct. And antibiotic should be given in all patients, and choice, again, the same thing. So antibiotic coverage should be, anaerobic coverage should be done when patient has previously undergone bilioenteric drainage, like a patient who has undergone hepaticojejunostomy develops a stricture. And these are the guidelines for duration of antibiotic therapy. In the presence of cholangitis, we need to give antibiotic for a prolonged long period of time. So whether to drain the lower bile duct, I was coming to that, because drainage, what does drainage do? Drainage will optimize the physiology. But in the absence of cholangitis, if we are doing drainage, the drainage increases the difficulty of surgery. This is right on the left side. We can see a patient who has undergone pancreaticoduodenectomy without biliary drainage. We can see the clear tissue plane, the thin bile duct, pancreas is good, and there is minimal blood loss, no adhesions, bile duct is normal size. However, when we do a drainage, we put in plastic stent, there is lot of fibrosis, lot of inflammation, the dissection becomes difficult, the operative times become more, blood loss increases. So all these factors, they determine the subsequent outcome in these patients. These are the a few. This is a meta-analysis which has been published some time back, where they have shown that drainage versus biliary drainage versus direct surgery, there is no difference in the mortality. However, adverse events were more in the patients who had undergone biliary drainage. However, the problem in this meta-analysis is that there is only one randomized trial which was conducted by the Netherlands group in 2010, and that was a multicentric randomized trial where they have shown the same thing. However, rest of the studies, they are retrospective and prospective. There is no randomized studies in this. But again, the crux is that if patient is not in cholangitis, bilirubin is not very high, we can go ahead with direct surgery if we are dealing with a patient with lower bile duct block. So cholangitis, so once we have decided whether to drain the patient, what are the routes of drainage? Endoscopic drainage is suitable for lower bile duct obstruction. Percutaneous drainage is required for upper blocks, and surgical drainage, although has been used in the past, but is not a preferred modality and should not be used as of today. Endoscopic drainage, again, if cholangitis is there, put contrast vehicle cannulation and just put a stent. And again, what kind of stent to be placed? There are a lot of options: putting an internal plastic stent, internal metal stent, or an external nasobiliary stent. So this is an example of nasobiliary stent which has been placed. This is a stone disease. The advantage of nasobiliary stent is that we can see what output is coming. It is easy to remove. The patient doesn't require a repeat procedure, and we can perform a cholangiogram at a subsequent date. The advantage is that there is a lot of bile loss occurring because of this external stent. It is discomfort to patient. There is risk of accidental dislodgement, and in patients with altered anatomy like hepaticojejunostomy, this is not a feasibility. ERCP stent, again, there are no bile losses. It is most physiological thing. Multiple stents can be placed, and however there can be technical failures, but again the stents can get blocked. They can get dislodged into the GI tract, and we need a repeat procedure for removal of the stent, and there is always a risk of pancreatitis associated with ERCP. PTBD, percutaneous drainage, is done usually if there is block at the hilum, and we need to drain the future liver remnant, the part of the liver which we want to preserve, not the other segments which are atrophied. And sometimes we need to put multiple catheter, and this is technically more successful and can be used in patients who have altered anatomy like hepaticojejunostomy. The disadvantage is bile losses, dislodgement, and risk of bleeding as has been seen in the meta-analysis. This is again an example to show a PTBD into the left ductal system. And this is example to show two PTBDs into the patients which have been internalized subsequently. So once we have drained the system, then what is the definitive treatment? Definitive treatment will be guided as per the etiology of the condition. Like a simple cholecystectomy will be sufficient for a patient who has undergone who has gallstone disease with bile duct stone and who has undergone a bile duct clearance. Bile duct exploration, if the stone is large and the patient needs to be stent has been placed and stenting has not been successful. Radical resection is required sometimes. This is a patient of recurrent pyogenic cholangitis who has been treated by left hepatectomy. We can see the stones in the intrahepatic ducts. Patients with pancreaticoduodenectomy requiring a vein resection after stenting and chemotherapy has been treated. Extended cholecystectomy with bile duct resection and hepaticojejunostomy for a patient of carcinoma gallbladder with obstructive jaundice. Left hepatectomy for a patient, and we can see the two ducts here, one duct here and another catheter in the duct. And left hep for a patient with hilar cholangiocarcinoma with caudate lobe resection. And so to conclude, obstructive jaundice alters the physiological state of the patient. Thorough evaluation and characterization is important. Cholangitis should be recognized promptly and treated. In the absence of cholangitis, biliary drainage should be used judiciously, and it is always preferable to do the internal drainage wherever feasible, and definitive treatment has to be carried out as per the underlying disease etiology. Thanks for your attention.
Thank you, Vikas, for very exhaustive coverage of the topic. So for the sake of postgraduates, again, I would like to reiterate some of the important points which Dr. Vikas has made. Obviously, the diagnosis of jaundice per se is not difficult because the patient himself or herself comes to us saying that I have jaundice. The first step is to differentiate between what is known as a surgical obstructive jaundice and non-surgical, which is either hemolytic or hepatocellular jaundice. Once we say that it is obstructive jaundice, then you have to decide whether it is benign or malignant. And once it is malignancy, then you have to decide what malignancy. And the four common malignancies which would cause malignant surgical obstructive jaundice would be gallbladder cancer in North India, but in other places, pancreatic and periampullary cancers, cholangiocarcinoma and gallbladder, and rarely metastatic lymph nodes in the HDL or at the porta hepatis. But you have to remember that in clinical practice, the commonest cause of jaundice per se is still hepatocellular jaundice. It is not obstructive jaundice. The commonest cause of obstructive jaundice is still CBD stone. The commonest cause of malignant obstructive jaundice, of course, would vary from geography to geography. In those of us who work in North India, it is gallbladder. But as I said, in other places, it could be pancreatic or periampullary cancer. The second important point is that the investigative algorithm today, as Dr. Vikas pointed out, invasive investigations like ERCP and PTC are not for diagnosis. So we would rarely do ERCP or PTC only for diagnosis, because whatever information we can get from these investigations, we can get from a MRCP also. and therefore their role is limited to therapeutic intervention. The commonest indication for which, as he pointed out, is to control cholangitis. And irrespective of the cause of obstruction, if the patient is in cholangitis, that becomes the first priority rather than the definitive management of the patient. Other than cholangitis, which is a definitive indication of biliary drainage, the indication whether a patient with jaundice has to be drained, the bile duct has to be drained or not, depends on what procedure is being planned. If you are planning a major liver resection, which is more than two segments of liver, most groups follow the Japanese philosophy, which is preoperative biliary drainage. Whereas for pancreatic resection and for extended cholecystectomy or procedure on the CBD like choledochal cyst excision or CBD excision for mid CBD cholangiocarcinoma, where major liver resection is not planned, jaundice per se is not the indication for preoperative biliary drainage. So that you have to remember. And what drainage you do depends on the site of block. For lower block, like in periampullary or pancreatic cancer, for mid CBD block, like in cholangiocarcinoma or gallbladder cancer, endoscopic drainage is preferable. For high block, a technically expert endoscopist can still drain, but usually you may require a percutaneous transhepatic biliary drainage. So that is how, when you get a case either in the exam or in your clinic, you proceed evaluating and working up a patient with obstructive jaundice for the final management. Piyush, you want to add anything to Dr. Vikas' presentation?
No, sir. I just want to ask, like,
Hmm.
uh, especially for liver resections, like it is advisable to have a biliary drainage. So, to improve the mitochondrial function and have to have less chances of post-operative liver failure. So, what is your take for, is there any difference for liver resections, whether it is right-sided or left-sided, or it's uniform?
Yeah, in fact, right-sided or left-sided rather than the side, it is the major hepatectomy. That means resection of three or more segments is the main thing which will determine the drainage. Even if we are doing a left-sided resection, we need to drain the right side of the liver prior to contemplating any resection. Basically, this problem occurs only in patients with hilar cholangiocarcinoma, we where the patient tends to lose lot of normal volume of the liver, which is functionally normal, but again non-drained. So I think it is
Yeah.
better to drain in patients who require major hepatectomy. Patients who require minor hepatectomy, less than three segment, two segments, left lateral segmentectomy or something like that, they can be done without drainage.
Dr. Shahidur, you would like to make any comment? Because in between, I missed some part of the presentation for some administrative work. So I hope you have dealt with this debate and controversy about preoperative biliary drainage with a very high bilirubin, but no cholangitis, especially
Yeah,
for
yeah.
pancreatic duodenectomy. Because
I
many
did.
students are asked this question
Yeah.
in the exam and they don't know how to answer
So
that.
yeah, there is a meta-analysis on this, and where they have shown that there is no difference in the mortality, but there is increase in infective complications in the term of surgical site infection, residual abscess, and there is increase in hospital stay. I showed the two pictures
Yeah.
of a patient undergoing pancreatic duodenectomy without drainage, where the bile ducts are thin, tissue planes are good, blood loss is less, operative time will be less, and compare a patient who has undergone pre-operative biliary drainage with a plastic stent, where there will be a lot of fibrosis, lot of bleeding, and operative time will be more, and blood loss will be more. So these patients will require a prolonged hospitalization. However, there is no data as of now where they have used a short segment metal stent for preoperative drainage of preoperative drainage, because contrary to the plastic stent, metal stent doesn't incite so much of fibrosis and inflammation. So we at the moment there is no clear-cut data on that.
I see some students there. I can identify Anirudh. Anirudh, if you are there, you want to ask anything to Dr. Vikas, this is a very good opportunity. Don't hesitate to ask. Yes, go ahead.
I actually joined the session very late, so I couldn't actually.
Speak closer to the mic. Speak little loudly. Yes, go ahead.
Sir, actually, I joined the session slightly late. I couldn't attend the initial part. So
No
I'll
problem.
actually, if I have any questions, I'll actually ask later, sir.
Okay. Okay. So if there are no other questions, Piyush, can we close the session?
Yes, sir.
So thank you, Vikas. Thank you, Dr. Vikas. Happy to have you again on Jaipur Surgical School, and we will be very happy to have you present something more from your experience, especially esophagus also. We would
Yeah,
love to hear
definitely, sir.
from you.
I will be happy to do that.